Okay, my disclosures very quickly. I've been given the brief today of talking about what's changed in HCC surveillance from the past to where we are today. It's a short talk, and there's a reason for that. So, in the beginning, we realized decades ago that people with HCC tended to have chronic liver disease. And then hepatology and other services have had to adapt in terms of what we do to try and manage the cancers that develop, but also try and intervene earlier for those patients. And that's really where screening came about. There's a lot of information in the diagram on this slide, but this tries to summarize where we've come as an international community in terms of screening surveillance over the last 40 years. What you'll see is that we use screening as a test for asymptomatic individuals, and the surveillance is because those asymptomatic individuals have a longitudinal risk, so a single screening surveillance test is not enough. You then have to perform surveillance repeatedly, and so there are questions about what the interval of those screening tests is and what the screening tests you employ are. And on the diagram on the right-hand side tries to highlight what the international and various guideline communities have recommended over the last 20 years. What you'll see is that not very much has changed. So it started with an ultrasound plus this serum biomarker alpha-fetoprotein. There was the biomarker fell out of favor a little bit, at least particularly in the US around 15 years ago, but has come back in, and you'll notice the Japanese society includes possibly more regular screening intervals, but also the inclusion of some additional blood biomarkers, which will maybe be discussed later. So things have changed a little bit, but not really. We are still fundamentally doing ultrasound and AFP surveillance, at least in the UK. This is where we were 20 years ago. This was the consensus statement in the Journal of Hepatology at that point. I'm going to highlight some of the key phrases in the summary. We know that we know the population at risk. It's mainly those with chronic liver disease, particularly those with cirrhosis. I think we're in agreement of that today. Not much has changed. We know that patients generally accept going into surveillance, although I'll maybe discuss that in a bit more detail, and that doctors generally think that surveillance is a good idea. Again, I would argue not much has changed. At that point, there was acceptance in the field that surveillance tests they were using at that time were far from perfect. And I think that remains the case. And there was this final statement about the need for research, particularly randomized controlled trials, to tell us about the efficacy, but also the cost efficiency of the sorts of therapies we were using. So shortly after that, this randomized controlled trial was reported, and this really remains the only kind of grade 3 evidence, although there was lots of problems with the way that this trial was performed, particularly in relation to applying this data to the Western world, the kind of health services we work in here. But fundamentally, large randomized controlled trial, 18,000 participants roughly, mainly with hepatitis B, obviously because it was performed in the Far East, and they showed an improvement of mortality. So that's the randomized controlled trial evidence in the field, 2004. So what's happened since then? And the answer is there's been loads and loads of publications, so about 3 a day on HCC surveillance if you average it out. But we haven't learned that much. We haven't had any additional randomized controlled trials in the modern era. There are reasons for that. We haven't really learned who can be cost efficiently included in surveillance, and we haven't really learned much apart from telling us that what we use at the moment is not that good and can be slightly improved by doing different surveillance tests. But we haven't really been informed as to what we should be doing for the optimal surveillance approach, I would argue. So what has changed? We're now including non-cirrhotic populations, particularly those with chronic viral hepatitis, and Hamish has touched on that already. We haven't actually managed to exclude patients with cirrhosis who are probably at the lower end of the risk spectrum. And I think there's a lot of interest in that. We've introduced more and more non-inclusion rules, but also stopping rules for people who are in surveillance where you think that surveillance is futile. So this is patients who are undergoing surveillance but don't have any realistic therapeutic options at the end. And that's obviously evolved alongside both HCC therapy, but also therapy for the underlying disease. So Hamish has touched on, for example, cure of hepatitis C, but also virus control in hepatitis B. And that influences not only the risk, but also how long these patients are living for, which obviously has implications for how we do surveillance. I think one of the things that has changed is our appreciation that patients need to be involved in the whole surveillance process. And certainly something I've learned in the last 20 years is that most patients that in the clinics that I've been involved in don't really understand why they're in surveillance. And I think we need to improve on that. So we have improved recall procedures. Some units have dedicated recall procedures in place already. That's obviously had to change a lot during COVID, where units were forced to employ slightly more organised recall procedures for patients in HCC surveillance. And we've had problems with applying non-concordance. So by that, I mean both clinicians not arranging the correct tests on time, or patients actually attending for their surveillance tests. And that comes down, I think, to education as well. So this is just data from a national audit in Scotland performed by the Scottish HBB network, auditing the many centres around Scotland as to who actually had a database of patients in surveillance. So only half in 2020, just as we went into lockdown, had any form of organised recall database for these patients. The other thing that's changed in the last 20 years is the surveillance tests we used. I've touched on that in the original slide. We still use ultrasound and AFP, but we have improved both the actual kit that we use for ultrasound as well as the reporting process, and we've improved training for ultrasonographers and tried to formalise that process, but that still remains a process that could be optimised further. And then the non-invasive tests, of which I've focused on AFP, but include other biomarkers, potentially including those in Japan. So this is just an example of a patient who was diagnosed with a negative ultrasound based on a rising AFP. One of the things that we know is that if you take the same blood sample and pass it to different biochemical labs around the UK, you get a different AFP result. So trying to have a specific cutoff for an individual patient about what is a positive AFP that should be acted on isn't necessarily something that we can apply universally in the UK, comparing data between centres. Secondarily, it's actually the trajectory of AFP that I think is really important at a personal level. We have patients who run persistently high AFPs that essentially we're constantly worrying about but don't have HCC by gold standard tests. And we have people who have low sub-diagnostic AFP levels that are rising who we've been able to diagnose HCC in. So I think we can use AFP better than we currently do. We audited that in the graph on the right-hand side, where we showed in patients who had HCC detected during surveillance that the majority had them detected by an ultrasound test, the AUSS arm in green, but that a significant proportion of patients detected with HCC actually had an AFP that led to their change in clinical management. And the shaded area of the blue bar that I hope you can see there at the top is patients who had had a negative ultrasound within the last 6 months. So a large portion of patients who are having standard surveillance are not being surveyed appropriately just by ultrasound alone. So these are the guidelines in 2023. I won't read them out, but essentially my summary would be not much has changed. We are a bit more organised with our recall systems. We have slightly better technology and better electronic records. But in terms of generational change, what has happened in the last 25 years, I think we're really stuck in this situation here. We're in Groundhog Day and nothing has changed, and we need to choose something about that, and I think that's why we're all here today. Thank you very much.